Good morning, good afternoon, and good evening, everyone, and welcome to today's Cutting Edge conversation titled Fighting Neurodegenerative Diseases, sponsored by PicnicHealth. Thanks for joining us today. Today, our guest speaker is Evelyn Pyper, the Senior Evidence Strategy Manager for Life Science Partnerships at PicnicHealth. She will discuss how Picnic is contributing to research related to neurodegenerative diseases. And this is a very exciting week for PicnicHealth, as just yesterday, they announced the closing of a $60 million Series C financing, which will support PicnicHealth in growing its portfolio of patient-centered real-world data cohorts across 30 new indications in complex, chronic, or rare conditions. Congratulations on this major milestone. My name is Megan Loy from Scientist.com, and I'll be your host today. Just before we get started, here are some brief notes to help you get the most out of this webinar. First, if the panels on your screen are too big or too small, you can zoom in or zoom out in your internet browser to adjust their size. Next up, the webinar is being recorded, and the video and its associated resources will be accessible on demand shortly afterwards. We'd love to hear from you and invite you to share any questions, thoughts, or comments in the Ask a Question panel shaking on your screen. We will be taking your questions in a Q&A session after the presentation. If you'd like to learn more about the research or technology presented today, explore the resources panel, where we've added a few relevant links and downloads. And finally, if you happen to have a technical issue, refreshing the page will nearly always fix things. But if it doesn't, please reach out to us using the Ask a Question box and we'll help you troubleshoot. All right, I'm looking forward to hearing from our speaker, but before I pass it over to her for presentations, I'm going to go over some quick background information regarding neurodegenerative diseases, as we've done with the rest of the topics during the Cutting Edge conversation series. I will briefly discuss a few of its challenges related to neurodegenerative diseases and why it's important for us to still be talking about this today. Let's start with a few definitions to get us all on the same page. Neurodegenerative diseases and disorders encompass a wide range of conditions that result from progressive damage to cells and nervous system connections that are essential for mobility, coordination, strength, sensation, and cognition. Neurodegenerative diseases affect millions of people worldwide. There are many factors that can lead to someone developing a neurodegenerative disease, the largest one being age. Some of the most common neurodegenerative diseases include Alzheimer's disease, Parkinson's, Huntington's disease, ALS, motor neuron disease, and more. The diseases are managed by a multidisciplinary team of experts that help patients handle both the physical and psychological management of symptoms. With that, I'd like to welcome Evelyn from PicnicHealth to the stage. Evelyn, thank you for joining us today. Feel free to take it away whenever you're ready.
Great. Thanks so much. Thanks for having me. Really excited to be here. Thanks to everyone for joining the session today. And especially big thanks to all of you who play a role in the pursuit of treatment for these devastating conditions. I know for so many people, myself included, the passion for this work really goes beyond a professional capacity, and the personal impact of these diseases is often felt, whether it's witnessing the impact on a friend or relative or through serving as a direct caregiver for someone experiencing a neurodegenerative disease. But within the research realm, we know that this challenging, non-linear journey from where we have been to where we are today and to the future breakthroughs that we hope to see for neurodegenerative diseases is made up of many connected components, from expanding our basic scientific understanding of neurodegenerative diseases and their underlying causes, to identifying better prognostic and diagnostic biomarkers, and finally to developing treatments to fight or even cure these diseases. And whether we're considering epidemiological studies, innovative clinical trial designs, or clinical effectiveness of treatments, it's data from patients in the real world that has a role to play. And so that's really where we're going to be speaking today. And so in terms of our objectives for this session, what we really want to do is connect the dots between neurodegeneration research, real-world data, and more specifically, patient-centric real-world data. We hope to explore some of the ways, such as unstructured data, that we can construct this more complete picture of patient health. And throughout this session, we'll touch upon a number of ways that there are challenging and opportunistic areas for real-world data in this space. All right, and no talk about real-world evidence is complete without first defining what we mean by real-world data and evidence. We know folks on the call may have varying levels of experience, from being very high touch, actively working to generate real-world evidence today, versus those that are maybe perhaps more traditionally in the clinical trial space. And so there's many different definitions that exist in terms of real-world data. In fact, there's even been publications on just how many definitions there are. But for the purposes of this session today, we're going to consider quite a broad definition. So real-world data being any data derived from settings outside of traditional RCTs. And once that real-world data is organized, interpreted, or analyzed, and then used to draw conclusions, that's when it becomes real-world evidence. We know that real-world data can be collected from a variety of sources, and you'll see here just a few examples, common examples that we see in terms of real-world data collection. And as you'll see, they differ based on what they are collecting, whether it be prescription data or medical records, as well as how and where they are collected, such as from hospital administrative records or from patients themselves. Now, the various real-world data sources that we just touched upon are increasingly being used by many health system stakeholders. And the question that might come to mind is, why is this the case? And the answer comes down to the proliferation of real-world evidence, policies, players, and potential uses of real-world evidence. So to give you an example of each, FDA is a great example in that we have this established real-world evidence framework for the last several years, as well as more recently developed several draft guidance documents that inform industry and other stakeholders on best practices for different types of real-world data. In terms of stakeholders, if we think beyond industry interests and beyond decision-maker acceptance, both of which are growing, we also have increasingly empowered patients and consumers. So individuals are really wanting to seek access to and govern their own health information. And finally, in terms of use cases, we're seeing a broader range of real-world evidence applications, from value-based contracting to personalized healthcare, all of which rely on real-world data in one way, shape, or form to deliver value to the healthcare system and improve care for patients. Now, when we think about these broad variety of use cases and the evolution of RWE, it means that it's no longer solely used for just post-marketing surveillance as it was traditionally. So this value really spans now clinical development, market access, reimbursement, as well as surveillance and sustained or expanded value demonstration. So with all of these potential use cases for real-world evidence that you see up here on the screen, drug developers and others are needing to think about real-world evidence plans even earlier in the product lifecycle in order to have research-ready and decision-maker-ready data at the time they need it. And if we think about what's at the core of all of these use cases, there are a few key needs by users of this information. One, the need to study the right patients. Two, the need to improve the probability of success of an intervention. Three, the need for faster, more efficient evidence generation. And finally, the need for patients, the right patients, to receive the right treatment at the end of the day. And having more data, having more real-world data over a longer period of time, and having a direct connection to patients helps to make all of these aims more possible. So there's no doubt that this is an incredibly challenging research area. And unfortunately, it's far more common to see a bad news story of rising prevalence of disease or failed drug trials in the news and in the media. And the little hope we have for this is that this is widely recognized and there's being action taken to fill these gaps in evidence. In fact, this recognition, I can directly quote the FDA recently, the effects of rare neurodegenerative diseases are devastating with very few effective therapeutic options available to patients. And this quote comes from the recent unveiling of the FDA's action plan for rare neurodegenerative diseases, including ALS, which was just released last week. And it's a 5-year strategy for improving and extending the lives of people living with rare neurodegenerative diseases. And what this signals, I think, is the need for increased investment, research in this area. And with the urgent need for new treatments, it calls for innovative research approaches. And real-world data certainly has a part to play in that. And so at the center of this session today, we have real-world data and evidence, which are not just conducive for research broadly, but for neurodegeneration research for a number of reasons. So first, the good match from neurodegenerative diseases and what RWE can offer comes from the complexity of the disease and various clinical considerations. So these are diseases with complex pathologies. There are multiple factors at play, and this can include cognitive impairment and behavioral health changes, many of which are underdiagnosed. In terms of clinical considerations, we see very diverse clinical features, as mentioned. Symptoms of interest could be really important, but challenging to pinpoint or to measure. We also can think about what it takes to study these diseases over long periods of time. The cost and time of trials is not insignificant, and there is certainly a complementary role to play for real-world evidence to do so in terms of our ability to look back, as well as potentially forward in a way that provides us a longer timeline at less cost. We also know that these diseases are very burdensome on patients as well as their caregivers, and real-world evidence offers a way to collect more data for more years with less burden on patients. So if we think about the demands of a trial, perhaps in terms of patients needing to go to a particular site or have certain tests, there is certainly value in having observational or slightly more passive or minimal data collection, even if that involves a prospective component. And finally, important to note that this is a really diverse and heterogeneous population, both within and across diseases. And unfortunately, clinical trials for various reasons often lack the ethnically, racially, or geographically diverse populations that we see in the real world. And often we can see exclusion criteria that are going to miss out on people with comorbid conditions or taking certain medications. And so without real-world evidence, we're missing important patient populations and the insights that they could bring to this research area. So I've spoken to why we need RWE to complement RCTs in this space, but why patient-centric RWD in particular? So beyond our first priority, which is, of course, this is the right thing to do by patients, patient-centric real-world data is actually going to drive better research. And as someone who has almost exclusively worked in real-world data, I would say that there is always value in using real-world data regardless of the disease. But neurodegenerative diseases in particular are an especially strong case for this. Where real-world data really shines best is when there's more to the story. And what I mean by that is if we think about any given patient with a neurodegenerative disease, maybe at the early stages of their disease where they're just starting to experience mild cognitive impairment, perhaps some memory issues, perhaps some physical manifestations. There's going to be quite a lot that happens in this patient's life before they even seek treatment or care. And there's also going to be a lot that happens even once they're diagnosed in between visits. So all of the rich data and information on what happens between those visits matters for this population. The other reason there's this more to the story component matters is because we know for many neurodegenerative diseases, what's happening at the cellular level does not always translate into clinical significance. So for instance, a treatment that might have an impact on particular proteins, it's not going to necessarily mean that we see improved symptomology. It's not going to necessarily mean improved quality of life. And so having patient-centric real-world data is going to help to fill in those gaps within the broader story. Second, we know that for neurodegeneration, data can span sites and specialists. This is often driven by the fact that we're seeing both cognitive, physical, and behavioral changes where different types of care might be needed. And so what we need to do here is bring together disparate data sources, and that starts with the patient themselves. They're the common thread throughout those data sources and the places where they have received care. And finally, caregivers are involved. And so it's important that we're empowering not just patients, but caregivers as well. And this can entail empowering them in their care journey in terms of how they seek care, in terms of owning their own health record and having a broader sense of their data that they've collected over time, as well as empowering them to contribute to research. I think a lot of patients in this space, there's a lot of need and desperation for treatment, and a lot of the value of research is certainly seen. We also want to recognize the symptoms, experience, and quality of life beyond kind of hard clinical endpoints. But important to all of this engagement and empowerment is that we're doing so in a way that doesn't place excess burden on patients and caregivers in terms of what we're asking of them. Now, I've spoken about patient-centric real-world data and why it's important, so let's discuss the how and how we go about collecting patient-centric real-world data in practice. So the PicnicHealth approach involves working directly with patients and caregivers and acting on their behalf to gather all health records and information from those records, which can include both structured and unstructured data. It's patient consent that drives the ability for us to go out and collect this information and use this data to support clinical care and access to their own records, as well as consent to research if they should choose to do so. In the near term, patients benefit from improved continuity of care, perhaps a lessened burden in terms of keeping track of their disparate medical information in a single place. But in the longer term, this research that's enabled by patient consent can also drive improvements in care and even the availability of innovative treatments. And so when we look at what this broader picture of collection looks like, with patient at the center and us working on their behalf, we're able to bring data together from all providers, whether that's primary care specialists, emergency care, all care sites, and all medical record information. And so I mentioned previously both structured and unstructured data. So what do we mean by that? Structured data you can think of is data that's already codified. So for example, has an ICD-10 code. And you can think of this as existing within some sort of table, perhaps, often within an electronic health record system. Whereas unstructured data falls outside of this, everything else in the patient's record. And it tends to come from narrative text, so sections of clinicians' notes and reports, but it can also include things like raw imaging files or DICOM images. And things like signs and symptoms, very important to the neurodegenerative space, are only going to be captured in these unstructured sections of patient records in most cases. And to give you a sense of the real impact that it has to include this unstructured information is this game-changing example here in a research project we did in lupus nephritis, where we leveraged unstructured narrative text and were able to identify 95% more patients versus using ICD codes alone from structured sections of the health record. So clearly a big difference can be made simply by including that unstructured data, which is something that we really pride ourselves in. And so our strong background in neurodegeneration and many of the disease areas that I'm going to speak about today in terms of the cohorts we've built really began with our experience in multiple sclerosis. And in that space, we have built a rich cohort of over 2,500 patients that are representative of the MS population in the United States. And in this illustrated example you see here on the slide, what we're trying to do is just demonstrate that the patient journey in MS, we really need sufficient longitudinality, so years of data that spans multiple providers and sites. So given the years of progression that this takes, it's important to see that we capture for this cohort 7+ years of data per patient. And this stands in contrast to many other sources like claims data where we might have only a 2 to 3 year window of capture in some instances. As mentioned, we also want to see We also need to see data from different types of providers. And in this MS cohort, we have an average of 5 providers per patient where we're collecting data from and averaging 3 sites of care per patient. So this breadth of disparate data and the extent of it, I think this is a really excellent use case. It's also a great example of what we need to go to the unstructured data for. And so you see here on this illustrative trajectory, the use of assistive devices, so like a cane or later on a wheelchair. This is going to be a major indicator of clinical disability and progression in MS. So it's important that we find a way to collect this information. But why do we need to rely on the unstructured data? So consider for a moment a patient with MS. If they don't file a medical claim to purchase their device, so perhaps a cane, it's not going to be captured in the claims data. However, they might have a conversation with their provider about their functioning and ultimately their use of a cane. And this important information can be found only within the narrative text, so the notes of the clinician. And as you can see here on this slide, in our MS cohort, 52% of patients, so not insignificant, end up requiring an assistive device for MS. And of those, another 38% of that group progresses to wheelchair use. And so it's important that we are able to abstract this information from the unstructured data. And our platform also enables us to layer on the prospective data collection component, which is also another way to gather this information, asking patients and caregivers themselves about their use of these devices or about other outcomes of interest. And so the combination of these two, or these on their own, are ways that we need to think about real-world evidence and the value it can bring beyond these, what's traditionally collected in an administrative source of data. And so to give you an example of our work in MS, I am showing here some of the work we've been able to publish. And the first paper here you can actually find included in the resources tab of this webinar. And I put it up here not to pat ourselves on the back, which all this work we're very proud of, but really to highlight that the custom abstraction methods that we've designed to abstract MS-specific variables, and this includes things like disability measurements, signs related to progression, assistive device use, MRI, treatment switch reasons, are all learnings and things we've been able to perfect in terms of our ability to abstract them. And we were able to apply these learnings into other areas of neurodegenerative diseases. And so this enables us to come in with a level of knowledge to address Parkinson's disease, Alzheimer's disease, Huntington's disease, and ALS disease in terms of information from patient records. So I'll be touching on a few of these today and look forward to keeping you posted on how these cohorts evolve over time. As of today, we have built a cohort of 1,500 Parkinson's disease patients covering all 50 US states. And one of the unique evidence generation challenges for Parkinson's disease is our evolving understanding of the disease. So for background, Parkinson's is increasingly recognized as a complex condition with both motor and non-motor clinical features, including some neuropsychiatric manifestations. And so the gap often seen is that past registries or chart reviews before we had this deeper understanding of Parkinson's may not capture the right elements to describe the natural history of Parkinson's disease to the greatest extent. And so what I want to highlight here are some of the common data limitations, as well as key data elements that we need to look for when doing real-world evidence in Parkinson's. So common issues that we see around generalizability and recency. So many alternative data sources may not be generalizable, both in terms of population elements, as well as I mentioned, some of those data elements in older registries that don't capture information around both motor and non-motor clinical features. As well as recency, unfortunately, the time it takes to collect, process, clean, and make available, many data sources are not up to date. And so we can miss some of that important recent information around patients, especially in these long-lasting diseases. As well, certain registries are focused more on incident or untreated populations, or a number of registries might not might rely too heavily on patient recall of symptoms and treatments, which can be an important but perhaps not an entirely always accurate reflection of treatments, especially when we think about looking back the last 6 to 12 months of someone's care. It can be challenging for anyone, and especially someone who's experiencing cognitive decline, to remember. When we think about key data elements we do want to include, however, it's important to keep in mind that these are critical, but they're not actually always done in routine care. So that's kind of the underlying thought process to all of these. It's the what do we need to collect and where might this exist? And if it doesn't exist, can we collect it prospectively? So important elements include comprehensive treatment histories, including treatment emergent adverse events, as well as scales that can be prospectively captured, where we know that clinicians are gathering this info, but we also need to find ways to engage patients more frequently. So this can be completed through patient-reported or caregiver-reported outcomes. And we also want to make sure we're including subjective as well as objective measures of disability, as I spoke to around assistive devices. And finally, for each of these cohorts, we really want to highlight here the specific insights that we can drive from unstructured data, which is, again, oftentimes the most challenging part to unpack and study. And so for Parkinson's disease, the text, physician's notes can help us better capture these motor and non-motor symptoms that might be quite descriptive in nature in the narrative text. And this can help us assemble clinical phenotypes of Parkinson's disease across multiple stages of disease. And so what I'll provide here is a really nice illustrative example, or actually a real example of a patient, 73-year-old female with Parkinson's disease. And there's a lot going on in this slide, but I'll try and summarize some of the key points. So one, when we think about treatments, our ability to look at a longitudinal treatment patterns in our cohorts is certainly of huge value to the research partners we work with. This information includes things like prescription, dose, and even reasons for discontinuation, which is often a gap in other sources. We can also layer onto this exploration of mental health. We know that there's psychiatric comorbidities with Parkinson's disease. And so if we think about this layered top, middle, and bottom section of the slide, the top of the slide, it might be what we get from a claims data source. They can tell you, when someone billed a prescription, but we wouldn't be able to layer on, using claims alone, the onset of mental health symptoms or progression captured using the UDPRS around symptoms and disability that might be collected prospectively. So when we start to layer on this information, we can tell you a broader picture of the story, why something might be happening, and not just that it has happened. Another really good example of this we can see in this slide here, looking at the mental health burden in Parkinson's disease. So here you see the high proportion of patients in the Parkinson's disease cohort experience any mental health disorder. And then within this group, the specific mental illness includes sleep disorder, anxiety, depression, cognitive deficiency, and psychosis. And this information may or may not come from formal diagnoses or ICD codes. We can take the approach both of using this coded or structured data, as well as leveraging unstructured data to obtain these insights. And another important note here in the case for real-world evidence is that we know that patients are more than just one thing. We know that Parkinson's disease patients might be excluded from trials based on existing comorbidities, but we know that it's just as important, if not more important, to understand these different subpopulations within the neurodegenerative space and how that might impact their clinical progression and how they respond to treatment. So moving on from Parkinson's disease and into the Alzheimer's space, we are currently building a cohort of 2,500 patients with Alzheimer's disease within the US. And in preparing this cohort, we have learned a lot about this space. We have learned that there's real industry interest in people with mild cognitive impairment who might not yet have a formal Alzheimer's disease diagnosis, where there's greater opportunity for intervention, and there's still so much that we don't know. This space is made even more complex by the need for specific imaging, so amyloid PET scans, for instance, which may not be covered by payers. So we know that reimbursement decisions around diagnostic tests can drive strategies for real-world evidence generation. And so what are the implications for real-world evidence and for the work that we do in this space? Well, this is a really good example of how healthcare system-related factors are not always accounted for in traditional trials. And if we think about data from different sources being needed to tell the full story, so not just claims, but imaging, and if we don't use these sources, consider that we might be missing, clear biases around patient groups that can't afford some of these imaging tests, and that represents systematically different patients, and we might miss their diagnosis, miss opportunity to receive treatment if we're not capturing their diagnosis through these imaging sources. And so patient level data capturing claims, health records, imaging, PROs, etc., can help unpack these many factors that are at play. And so when we think about Alzheimer's disease, we know some of the challenges with existing data sources are disease staging not being available. There's a long disease course, and we need sufficient look back and forward, as well as recency, which mentioned previously. It's important given this competitive and ever-changing treatment landscape and all of the diseases in the pipelines coming down. When we think about key data elements in this space, a really important one that we want to highlight here is the onset of cognitive impairment. So as mentioned, especially given industry's interest increasingly in these early stages of disease before formal diagnosis, we need to think about both the patient and caregiver and how they might notice onset and be a source of reliable assessment in a way that only working with the patient can provide. Of course, there's interest in diagnosis, symptoms, comorbidities, treatment and dosages, as well as treatment emergent AEs and biomarkers. This is something we can also capture by having patients at the center and us being able to act on their behalf to collect all this information from a variety of places. So this might be labs or from primary care, and we can collect things like CSF biomarkers, for instance, in Alzheimer's disease. And we want to be able to cast a wide net in this space. So whether that exists in labs or primary care, it's important that we have a flexible real-world evidence plan where we can seek out this information, recognize where it's being found most, where it might be underrepresented, and cast a really wide net. And finally, in terms of our unstructured data use case here, unstructured data can really help to overcome these gaps that I mentioned for Alzheimer's disease. A great example is that we can use narrative text abstraction to access scores of diagnostic exams and other mentions of physician or neurologist assessments of cognitive impairment. So this includes the mini mental state exam and the Montreal Cognitive Assessment. And finally, moving on to Huntington's disease, we're really excited to also be launching in this space a cohort in Huntington's disease, which for reference is a more rare inherited disease that causes uncontrolled movements, emotional problems, and cognitive impairment. Again, we're learning a lot in this space that enable us to provide the best data and real-world evidence possible to our partners. So limitations that we're really mindful of with common data sources is that there may be this large established research base through longest-standing registries, but unfortunately much of this existing data ecosystem is siloed and incomplete. So we certainly see a role for PicnicHealth to play here. I also want to call out genetic information is often missed, and mutation information may not be captured in traditional sources and in the health record. When we think about key data elements for Huntington's disease, like other neurodegenerative diseases, we're importantly looking at age of onset, date of diagnosis, patient-reported outcomes, functional assessments, as well as cognitive assessments, and there are a variety for this disease. With patient consent, we can also connect to any data where the patient has data, really, versus any other providers. And this will inform our overall understanding of Huntington's disease. And we can customize abstraction for things like assistive device use, again, which is relevant for this population as it was for MS, things like weight loss, cognitive impairment, and onset and progression measures are all really buried within that narrative text. Now, I have already introduced a number of real-world data challenges and opportunities for each of these diseases. But if we also look across all of these neurodegenerative illnesses, there are some cross-cutting themes that we see. And one of which is the desire to target specific patients, which has its own unique challenges and opportunities, as you see here. There's many critical endpoints, and many of which are actually not being implemented or measured in routine care. And this could be because they're not feasible, they're not consistently captured, but it's always important to explore alternative ways to get at these key endpoints. And we're learning the nuances of what it takes to do so. And so for challenges, this could mean coming from inconsistent scales for staging. This could be the difficulty of defining what is early stage versus late stage for any given time point for a patient. It's certainly a long spectrum as opposed to a very well-defined category. We also know that progression differs across patients in terms of this pace, in terms of what it looks like, in terms of symptoms. And finally, the challenge exists in terms of differentiating between symptoms. So for Alzheimer's disease, for instance, what is mild cognitive impairment versus what is dementia, and then what is Alzheimer's dementia? That can be really challenging, and it takes a lot of data to clearly define for a given patient at a given time. Despite these challenges, there's a lot of opportunities that exist, both through PicnicHealth offerings and others. There might even be folks on the call who are working in the space of wearables and mobile apps, which are critically important in neurodegenerative diseases to measure things like motor function in real time, in the real world, in the comfort of patients' homes. There's also great opportunity in how we capture cognitive, emotional, and social changes through patient-reported outcomes, which again can be done directly through patient devices. And finally, there's real opportunity to capture diverse spectrum of disease stages and severity and symptoms, all again through unstructured data in combination with or on its own with structured data. Now, we're talking about patient-centered research, and I've talked a lot about research, but what does this patient-centric approach mean for patients themselves? Well, working with patients enables us to do this great work, but empowering patients and their caregivers is central to this. So again, empowering them to be involved in research, to own and govern their own data. It's also important for the inclusion of the patient experience, no, not just outcomes. And any of us that have been a user of the healthcare system knows that so much of what we want captured and researched exists based on what we share, our own experiences, symptoms, and not just what is said in the record. We also know that patient-centered research helps us better characterize quality of life, not just quantity. And finally, working with patients enables us to collect more data and can help us have a better understanding of disease from epidemiology, treatment effectiveness, and all over a longer period of time. So I wouldn't want you to leave this webinar without actually showing you how we do this, how we do this patient-centric real-world evidence. And so how our studies typically work at PicnicHealth is that patients sign up electronically. It only takes about 5 or 10 minutes, which again is key for this population and minimizing any excess burden. And patients consent to PicnicHealth collecting the medical records on their behalf. PicnicHealth then goes out and collects complete medical histories and prospective records and creates custom de-identified data sets. The data is then enhanced through multimodal approaches, so we can include things like PROs, claims linkage through our partnership with Komodo, and through this patient-centric approach. And finally, patients are empowered to, on their own health history, to use it with on the device. So you see on the right-hand side of the slide here, what a typical patient timeline might look like. So they're able to look back, forward, get details of their care that they've been provided at different sites, and essentially received a digitized version of their health record on this PicnicHealth timeline. And I know many folks on the call will be focused in the space of neurodegenerative diseases, but the fact that we're growing and the exciting announcement yesterday, as mentioned at the beginning of the session, is really enabling us to work across a greater range of diseases and provide this offering both for patients and researchers for a broader number of patients. And so as you can see here, we have a number of fully enrolled, so existing cohorts that we have set up that span a number of neurodegenerative and non-neurodegenerative diseases. We also have a large number of cohorts that we are enrolling this year, and we're really excited to continue to do research work in this space. And then finally, we have a number of pilots launching where we're exploring cohort opportunities and identifying what's needed to take these diseases on the right to that fully enrolled cohort space where it can benefit both patients and researchers. So I'll leave this up for a moment here. This is something we'd really love to talk to folks on the phone about after this call. I'll certainly include my email in the chat and in follow-up so folks can reach out whether or not you're working in neurodegenerative diseases. And before we wrap up, I do just want to include for folks that are interested in how they might work with Picnic Health in this space, there's a number of ways we worked with research partners, and the three kind of common lanes that this takes is one, licensing an existing cohort. So working with us to access one of the existing cohorts I showed on the previous screen, where it's an area where we have already gone out, collected information from patients. Patients are using our platform already. Another way to work with us is through requesting a new cohort. So perhaps the data you need doesn't exist elsewhere, but Picnic Health can build a cohort that we can all benefit from patients, researchers, and this all enables us creating a custom curated deep data set. And in fact, many of the cohorts that you see established really comes from us having an ear to the ground and working with partners on where is there high unmet need and where is there a need for real world evidence in this space. And then finally, we can also work to build a virtual registry. So you might have patients that you want to study, and our platform can be used to manage enrollment for data collection and to have that engagement with the patient through our platform. And so to wrap things up before we head to Q&A, to summarize, we know that this is a really complex space. It's challenging, but the future really is promising in neurodegenerative diseases. There's an ever-growing patient population and needed of evidence to bring us closer to diagnosis, to management, and treatment of these diseases. And there's elevated recognition and importance by top researchers as well as pharmaceutical innovators of this need. There's over 100 drug assets in development and in trials. And what we're really excited to do is work in this space to partner with you regardless of what stage of disease or what part of the healthcare ecosystem you're working in to generate real world evidence to help make a difference in this space for real patients in the real world. And so with that, I will pass things over to the Q&A session.
Thank you, Evelyn. That concludes the presentation portion of this event, and we'll now move into the Q&A. As a reminder, if you have a question, you can submit it using the Ask a Question panel that you saw shaking on your screen earlier. Okay, let's jump in. Evelyn, how do you leverage the unstructured data from the patient record, for example, clinician notes?
Yeah, that's a really good question and certainly one we get often. So if we think about all of the potential solutions that exist to extract meaningful insights from the narrative text. And actually, I will bring up for reference a slide that really helps depict this. So here, as you can see on the slide, there is unstructured narrative text on the left. So you can think of this as notes, as sentence form. And there's a number of solutions out there that exist on the spectrum of fully reliant on machine learning to 100% manual human abstraction of records. And the way I like to think about our approach is that we have this sweet spot in the best of both worlds where we have human in the loop, where we're essentially leveraging our AI processing engine and those capabilities, but combining that with the correction and contextualization that only a human can provide. And many of us know that relying entirely on AI, despite its efficiencies, does not necessarily get us to the level of accuracy and nuance that we need for looking into health records. So for instance, the example you see here, we're able to use this combination of human and AI processing to get from this narrative text to a more structured form. So for something like medications, you can see here we have row and column format. We have both the drug information as well as information like start and end date, and even stop reasons, importantly collected in the data. So hopefully that helps provide it, but also we know this is of interest to folks, and definitely direct people to the resources tab, particularly the publication around MS that really explains this process as well, and an excellent use case of it in action.
Thank you. Another question for you: how generalizable is your data to the U.S. patient population?
Yeah, this is also a great question, and one we receive often from partners, because we know that generalizability is not just important to patients who want to be able to see patients that look like themselves reflected in the data, but it's also important to decision makers like the FDA, who need to ensure that the data that they're assessing and that's included in a submission, for instance, is reflective of the patient population in the US. So a really good example of this comes from our work in MS. And so I'll bring up this slide here. So as you can see here for MS, we have really excellent geographic coverage. So these 2,500 patients come from across 50 US states. And then on the right-hand side, you can see when we're comparing demographic characteristics like age and sex to the US population, we have a really consistent age distribution, proportion of male and females. And then finally, in terms of race, we know race is really underreported. Unfortunately, only about 40%, unfortunately, up to 40% of MS trials don't include data on race. And when it is reported, only about 2% of MS trial population is Black or African-American participants, and less than 1% are Asian patients with MS. And so we know that important groups of patients are being underrepresented. So in contrast to that, for our MS cohort, we have greater representation at 17%, Black and 7% Asian respectively. And this increased representation and diversity is something that we only continue to strive for within this disease, as well as across all of our cohorts. So there's no kind of single threshold of good enough. I think there's always more we can be doing in our recruitment and the research that we do to make sure data is generalizable and that we're not contributing to this underrepresentation in research.
That was very interesting. Thank you. Speaking of participants and the patient data, how do you get them to participate in your platform and share their data?
Yeah, so this takes a number of different forms. And a good example, I'll speak to this one. So because we're working across many disease areas, there's not necessarily a one-size-fits-all approach to recruit. So the patients enrolled through typically a multi-pronged approach that's catered to that population. And these approaches include things like digital channels, community and advocacy groups. So this can be national, regional, local outreach programs and partnerships. We also work with partner companies, so labs, genetic testing services, pharmacy benefit managers, and then finally providers. We work with a number of KOLs in different disease areas, as well as large community specialty care centers. So this kind of customized approach for the given disease really helps us get to patients and get this generalizability that I spoke to on the other slide.
Thank you. Do you think that increasing awareness of degenerative diseases and the causes can help in avoiding some of these diseases?
Yeah, so awareness of the diseases and their existence in patients?
Yes, and their causes.
I think so. I mean, I guess the challenge is that so much of this is connected. So we have, there's certain work that really needs to be done in the clinical trial space. I think that awareness raising is key in terms of patients, caregivers, and people that might not even know that they're a patient or will be a caregiver, being able to recognize the signs and symptoms of an illness before it progresses to a worsened state. So I think particularly with like the aging population that we see now and the increased risk for these diseases, I certainly have seen in the last 5-10 years increased awareness around these diseases. And I think the more that we talk about these diseases, not just from what we're seeing clinically, but in terms of signs, symptoms, experiences of patients, I think absolutely it can assist in research in this space. And the more people that want to contribute, their information for their own management, but for the purposes of research, I think the better.
Agreed. I think it can also help patients advocate for themselves if they have a deeper understanding of the causes and connections. Thank you. And then a final question. Do you think nutritional intervention could assist in preventing some of these groups of patients from becoming ill, I suppose?
It's a great question. I mean, I won't pretend to be a neurodegenerative clinical research scientist in this space, nor am I doing any active trials on nutrition interventions. But I absolutely think that as a real world evidence specialist, I would say that being able to answer those questions really hinges upon us being able to observe patients and their nutrition habits, past, present, future, in the real world. And so if we think about one of these cohorts, and if there's a hypothesis a researcher has around nutrition interventions having a role to play, our ability to be connected directly with the patient, have that health record information to see how they're doing, and have perhaps patient-reported or caregiver-reported measures of what that nutrition intervention looks like is going to enable us to answer these really important questions. So absolutely think it's worth asking, and outside of a controlled setting, there's certainly rich information that we'd love to explore.
Excellent. Thank you, Evelyn. And thank you to everyone for joining us for today's presentation. Big thanks to Picnic Health for sponsoring this cutting edge conversation. And we now invite you to take a moment to share your feedback on the survey. We'd really appreciate your input. If you still have a question, it's not too late. Feel free to send it in now and we'll forward it along to Evelyn following the event. If you're interested in learning more about Picnic, we invite you to check out the resources panel. And you can also watch the entire cutting edge conversation series on demand. Simply click the button on the slide to find out more. In closing, we hope you enjoyed this Scientist.com webinar, and we'll see you next time.